Good evening. I really appreciate the opportunity to speak with you today. I'm sorry we can't be together in person, but I appreciate the organizers inviting me to give this lecture on the impact of COVID-19 on endoscopic practice. I'm Klaus Mergener. I'm the current president of ASGE. More importantly, I'm a clinical gastroenterologist in the Seattle area, and I will try to address the impact of COVID-19 by making just a few remarks related to the economical impact as well as the medical one and the personal one, by which I mean the impact on us, on our teams, and on our patients. Before I do that, it's important to remind ourselves that this pandemic started just a little over a year ago. As we all recall, with the first reports of a new type of pneumonia out of Wuhan, China. And then very, very quickly, we saw the rise in total cases and deaths that occurred worldwide. We're now, as of this week, at the unfortunate point of crossing the 100 million milestone in terms of total cases, with about 25 million cases having occurred in the US. And likewise, there's been more than 2 million deaths, with, again, almost a quarter of those occurring in the United States. This, of course, is by no means the first pandemic that has hit this world. It is the first such event in our professional careers. But there have been several, as is listed here in this table, over the years. For those of you interested in the history of infectious diseases, I recommend this excellent review by Tony Fauci and colleagues from Cell last year. As you see, in the 500s and 1300s, there have been plagues that have essentially erased almost half of the world's population. COVID is the first respiratory virus-related pandemic that has occurred in our lifetimes. As this article emphasizes, it may by no means be the last one. There have been several smaller scale epidemics related to SARS-CoV-1, H1N1, MERS, and other agents that have occurred over the last decade or two. And the reason the frequency seems to be going up may well be related to human travel habits and other lifestyle issues that have changed over the last few decades. So while we're hoping this may be the only time we're seeing this kind of a dramatic event happen, it may not quite be that way. Now, fortunately, of course, for all of us, there's been rapid progress in the medical knowledge and science related to COVID-19. And as is listed on this slide, just looking at the first few weeks after we became aware of this new disease, after it had been reported to the WHO, the virus itself was isolated only 7 days later. And then only a mere 3 days after that, the full genome had already been sequenced and published. And once again, 3 days later, a first validated PCR testing protocol was shared and published. This kind of rapid progress was possible because there had been previous coronaviruses known since the 1960s, and specifically SARS-CoV-1, which caused a more limited epidemic 10 years earlier, had been very well studied, and a lot of those learnings could be translated as the new SARS-CoV-2 coronavirus was detected. Likewise, vaccine development for COVID-19 was very rapid, would typically take 15 years for a new vaccine to be developed. In this instance here, the development was compressed to 10 months or even less for three reasons. One is, again, other coronaviruses had been studied, and the preclinical studies related to those viruses could be used to some degree in the development of the SARS-CoV-2 vaccine. Secondly, the phase 1, 2, 3 type of clinical trials happened in a very compressed fashion in parallel. And thirdly, the production of the vaccine itself was started long before the clinical trials had been completed, at risk to the companies, at significant financial risk, but realizing the importance of getting vaccines quickly, that was done. And therefore, in a little bit less than a year, we had the first vaccine candidates. Now, in our country here in the US, there are several major candidates currently. We have two that have been receiving emergency authorization, the Pfizer and the Moderna vaccines, and vaccination programs have been started using those two products. There are several other candidates, including the AstraZeneca, the Johnson & Johnson, the Novavax vaccines that are anticipated entering the US market very soon. They have some differences in terms of type of vaccine. The first couple of them are mRNA-based vaccines. The other ones are sort of more traditionally manufactured vaccines using an adenovirus as a vector. But be it as it may, all of these may soon be available in our market. In other parts of the world, as you all realize, there have been Chinese, Russian, and other vaccines that have already started entering the markets in various countries. There are many open questions related to the currently used early vaccines, related to durability of their response. We don't know how long immunity will last. There's some good early data suggesting that there will be a durable response lasting several years, but details need to be confirmed. The degree of protection is somewhat unknown, meaning that we do know from the early trials that the vaccines prevent severe disease, severe illness. What we're less certain about is whether or not they will also prevent infection itself. And if that's not the case, if a vaccinated person can still be infected, whether or not that person can also then still transmit the virus effectively. And last but not least, there's a lot of debate currently, as we've all seen, around the issue of vaccination passports. Should vaccinated individuals be issued statements and passports and therefore then be treated differently from not yet vaccinated individuals? And there's not just medical, but a number of ethical, political, and other concerns that are currently being debated in a variety of countries. Turning now to the impact of COVID-19, as we all know, there's been a massive early global impact of this disease. In our country, the Medical Group Management Association, MGMA, reported that, not surprisingly, virtually all GI practices experienced a negative financial impact related to having had to shut down endoscopic operations. Dr. Parasa and colleagues performed a survey globally with the help of the World Endoscopy Organization, published in Gastroenterology last year, documenting that, again, not surprisingly, most GI groups globally had to cut back on their procedural volumes massively at the beginning of the COVID pandemic, largely related to the availability of or shortage thereof of personal protective equipment. And last but not least, even our trainees obviously have been significantly affected, as published by Rommele and others from Helmut Messmann's group in Augsburg, Germany, showing that trainees experienced a decrease in procedure volume of 90+% during the early stages of the pandemic. The economic impact of COVID-19 has been significant certainly in our country. And I need to take a minute to briefly explain GI practice in the US to emphasize the importance of the economic impact. In our country here, several decades ago, most endoscopies were done hospital-based, where the hospital owned the equipment, and the gastroenterologists were simply going into the hospital performing the procedure. Then, over the last couple of decades, more and more GI practices have developed what's called ambulatory endoscopy centers, where they themselves, the physicians, own the equipment, meaning they carry significant expense and they own assets, including the facility itself, all the endoscopic equipment, and therefore having to pause endoscopic operations and shut down these ambulatory centers has a significant impact on the their financial well-being. As is shown in this slide, whether or not practices did okay as they were working through the pandemic essentially related to the issue of how quickly after the pandemic started and revenues, as shown in the blue line here, started declining, how quickly after that point were they able to do one of two things. Number one, cut their expenses also to decrease expenses and therefore improve their cash flow. And secondly, how quickly could they recover their revenues by, for example, doing telehealth and ultimately reopening their endoscopy centers. Now, all of those responses were more easily achieved with professionally managed groups. So smaller groups that were not as well managed have seen a higher economic impact than some of the larger groups that oftentimes are affording more professional management. Besides the economic impact, there's a significant personal impact that has been occurring related to the pandemic, as we all realize. We are taking care of people, but at the same time as leaders in gastroenterology, we also take care of people who take care of people, meaning we take care of our own team members in our GI groups. And in good days, there's a risk of us sometimes forgetting that issue. So as we were encountering this new challenge, this pandemic, it has been a great reminder to all of us that communication is extremely important, not just communication with our patients about that it's safe to come back and have endoscopies done, but also with our staff members who have seen our operations shut down. They started worrying about their jobs. They saw lots of changes happen very quickly, and they didn't always know why they were happening, how quickly they would be reversed. So what needed to happen in many of our practices is much more frequent communication than we would have otherwise done. Frequent huddles, getting together, in the case of my practice, every morning, essentially talking about what's different today, what do we need to do today to adapt, being very transparent in terms of our decision making, and also supporting our staff both internally and providing them with advice in terms of external resources if they did have to go to part-time work to be able to hopefully cope with the situation. So the culture of teamwork, which is, of course, always important in our operations, became even more important during the last year. And it has been a great reminder, I think, to many of us that gastroenterology is not just doing procedures as quickly as we can. That tends to run a risk of becoming a little bit of an assembly line type of activity, almost like building a car. but we are much more than that in a well-functioning GI practice. And the pandemic, if nothing else, has reminded us that the interpersonal communication and the teamwork piece is at the core of everything that we do. And last not least, in addition to the economic and the personal impact of the pandemic, the medical impact is significant, and it is yet to be understood in its full impact, and we'll have to see how this plays out over the next few months and possibly years. We had known long before COVID that delaying colorectal cancer screening, which is one of the core activities that we do in gastroenterology, certainly in our country here in the US, with a colonoscopy being very heavily used for colorectal cancer screening, the impact on diagnosing colorectal cancer if we have to shut down endoscopic operations for a prolonged period of time is significant. We have known this from studies pre-COVID that looked at stool testing as a screening tool for colorectal cancer. And if a follow-up colonoscopy gets delayed after a positive stool test, what's the impact on colorectal cancer diagnosis? And as is shown in this slide, from a couple of studies, if we delay performing a colonoscopy beyond 6 months and certainly beyond 12 months, as is shown here on the right-hand side of the slide, the risk of colorectal cancer in those patients who had a positive stool test goes up twofold, and the risk of finding advanced stage colorectal cancer goes up even higher. So there's a significant medical impact to delaying performance of endoscopy, hence the importance for all of our practices to reopen endoscopy operations as quickly as possible. And as we have reopened our endoscopy centers, certainly in this country, what became extremely important is to figure out a way to triage and manage the backlog that had occurred of cases that needed to undergo colonoscopy. So we've all developed sort of a prioritization scheme of which subgroups of patients need to be done first, second, and third. And some of this is shown here in this slide, and I won't go through all of the details, but we obviously want to get patients who had positive stool tests or have symptoms to the front of the line and get them screened as quickly as we can, considering also issues related to the patient's age, comorbidities, and other factors as listed here. Lastly, if anything good came out of this pandemic, in addition to, as I said before, the reminder that this is really a team effort and we need to be mindful of our team members and help each other, it is in our country here in the US, where we have 3 GI societies. It's the fact that this has brought the different GI societies closer together. We have developed a number of joint statements to help our gastroenterology members cope with the current situation in the pandemic. And I am certainly hopeful that ASGE, which is the society that I'm currently leading, will continue to experience this kind of a team spirit with ACG, AGA, and the Liver Society going forward. So in summary, what have we learned from the last 12 months? Number one, we're all not invincible. Gastroenterology has been a very successful and in our country, very profitable specialty. This has therefore come as a complete surprise to us, but we are resilient. It took us a little while, but we have now learned how to deal with it. We do need to be prepared, as I said early on, for potential additional pandemics that might happen over the next few decades, and we need to put ourselves into a situation where we can respond quickly. The basic tenets of practice management are important. To quickly be able to cut expenses when necessary, to quickly figure out ways if we had to shut down endoscopic operations to recover revenue is going to minimize the economic impact. Taking care of our team members is important in terms of addressing the personal impact of a pandemic. Networking and learning from each other always matters in these kinds of situations. There's a saying in our country that 90% of innovation is sourcing, meaning it's learning from each other. You don't always have to reinvent something, but just learning how others are doing certain things and are reacting is very helpful. And last not least, the medical impact and the full impact, therefore, of COVID-19 is not fully known currently and won't be known for some time. So once again, I appreciate the ability to talk to you all, and I look forward to our question and answer session. Thank you again.
Thank you, Klaus, for this wonderful lecture. May I request Dr. Kocher and Dr. Anup Saraya to have any interactive questions?
Yes, that was a wonderful talk, and bringing out the main features of this COVID experience, that there was suffering on part of the patients, training has suffered, and of course the financial implications. I think in India we have not yet come back to the pre-COVID levels in terms of endoscopy. For the reasons that we just have started with vaccination, and as it picks up, probably we'll be more comfortable in having the full outpatient services and full endoscopy services. Indeed, patients have suffered. Those, for example, those on variceal band ligation, those on even diagnostic procedures for all kinds of GI diseases. Predominantly, I would say inflammatory bowel disease has suffered the most. And of course, the therapeutic procedures have been delayed. All kinds of procedures got delayed during this period. And it'll be interesting to know from you that have you come back to the pre-COVID levels, and how are the services now?
Yeah, thank you for those comments and for your question. In this country, in the US, we had intermittently come back to pre-COVID levels of performing endoscopy and seeing patients in clinic, I would say during the late summer or early fall of last year. Volumes definitely picked up, but now we're in a second wave situation where many practices had again to slow down, if not completely shut down. So we are once again at a point where we're significantly down, both in terms of seeing patients and performing endoscopies. And as you point out, and as I was trying to say towards the end of my talk, we will not know the full impact of this, I think, for quite some time. Not just in terms of immediately being able to take care of patients who need us today, but also the important issue of delayed diagnoses that will most certainly happen over the next few years of patients who just had to have their services delayed. If I may add one more comment, which I've tried to make in my talk, but maybe not emphasized enough. I don't think we can emphasize it enough. In your country and your culture, you know, from what I know from many friends, you are quite humanistic in your approach and are very well connected with the humanities and the arts, and we saw it during your beautiful opening ceremony again today. In a culture like the United States, where much is driven by economic realities and finances, there's a risk, especially in a specialty like ours that's very procedural, that we forget the personal interactions side of our specialty. And I think if COVID has done anything for us here in this country is to remind us how important it is to take care of not just our patients, but also our team members and each other, and keep each other supported during these busy times. So I think that's something positive that we will take out of this pandemic and hopefully carry forward.
The training, how are the fellows going to cope up with the lost year?
Very difficult, and they are asking that same question to all of us as teachers. They have lost essentially almost a year of hands-on training. We have worked very hard, as has Dr. Greenwald with the ACG, to replace some of the training as much as possible with virtual sessions, providing video clips, showing videos of endoscopies and endoscopic techniques, but that cannot, as we all know, fully replace the hands-on experience. So they will have a certain deficit there. As soon as things reopen, we are certainly planning to provide extra courses and hopefully extra money to get these fellows to some of these additional courses, but it may not fully make up for the deficit that they've experienced last year. It's a very important issue and a good question.
I think, Klaus, the one issue that is the financial one may be important for other people here also, but both of us, me and my co-chair, both are from government setup, and for us, economic loss is not of that nature. Number one, the biggest casualty is training of our residents. In fact, in a small department, we have 7 or 8 faculty members and 20 odd fellows. Out of that, 7 were down with COVID. Fortunately, none developed a severe disease. And 12 staff nurses and 17 other employees, they also developed this disease during this phase at our center. And our load has gone down significantly. Around, you see, we were doing around 100 to 150 procedures a day. That came down to, during the peak, it came down to around 10 to 15% of those procedures. And mostly we were doing emergency procedures or urgent procedures, not the routine one. We are gradually limping back to the normalcy. Now we are doing around 40 procedures a day with all precautions. So we take pride in saying that we are not charging anybody for any procedure in our country, at least in these 2 institutions, I can say. And so economic loss may not be of that nature to the hospital or to the doctors, but definitely the academics has suffered a lot, and people have suffered a lot. Those who are sick, they could not come. The disease stage has advanced, especially in GI malignancies. We know for certain that in certain cases, they could not make it to the hospital due to lockdown. So it has taken a heavy toll. And endoscopy services has suffered to a great extent. Infection control is concerned. There also, in the beginning, we had some problem with the PPEs in the beginning, that somehow the hospital could procure more. And so that was also a limiting factor in the beginning, and people were scared. The scenario will change. And I can see one thing is, you see, we are thinking that now vaccine is available, so more and more people will feel confident. But here in our center, people are still apprehensive because the government has cleared those vaccines, but efficacy data is not in public domain. So people are also apprehensive. They are not willing to take vaccine. That is also one important factor. So probably it will take some time in this part of the globe to start normal functioning as far as endoscopy services are concerned.
Thank you for those comments. And many of the aspects you mentioned are very similar in our 2 countries. Specifically, the last issue you mentioned, about patients being apprehensive and somewhat fearful to come back to us. It will take a lot of effort on our part to educate them, and in our country, the referring providers, the primary care specialists who refer patients to us, to tell them not just about the vaccines and their safety and efficacy, but also all the other things we're doing in our practices to try to keep our patients and our team members safe. And our practices here in this country have certainly started doing that. You again emphasize the significant toll this pandemic has taken on our trainees. And, you know, to some degree, there's no perfect answer in terms of how do we make them whole? How do we get them up to, you know, the training they would have otherwise gotten without a pandemic? There is no perfect answer. I think what all of us can do and need to do as leaders and teachers is to, in times of crises, to commit ourselves to work even harder than we usually do on behalf of not just our patients, as I said before, but also our team members, including our trainees, and do the very best we can going forward as we come out of, hopefully, this pandemic very soon, to help them to catch up on some, at least, of the training that they've lost. But there is no perfect answer. And I could not agree with you more. We could have a whole conference, maybe we will at some point, on the different health care systems in different countries. And it is well known that the United States healthcare system is very problematic, very fragmented. And, you know, I wish over here we had some elements of other healthcare systems like yours and some of the European ones that can provide government assistance better than we can in this country. There's problems with healthcare systems in every country, but this certainly highlighted for us in the US the sort of the maybe overly strict focus on economics in medicine. And that's why I emphasize that quite a bit in my talk here. But I want to, once again, in closing, encourage all of us and remind us of what we know, that we are here for our patients, for our fellow human beings and our trainees, our team members. And again, the pandemic, I think, has been a very powerful reminder to all of us for that.
Well, thank you, Dr. Klaus, for showing us what you have gone through and what the world is going through. And let's hope that we come out of it fast. Thank you very much indeed. Thank you. Namaskar.
Thank you.